This will be the visual and audible representation of the scientific article written by KevinCoulier, ViekeDeRuyter and AngeliqueVeracx. Obstructive chronic respiratory diseases affect the airways and cause an impairment of the exhalation. The most common forms of obstructive CRDs are asthma and chronic obstructive pulmonary disease, COPD. In Belgium, 3.7% of the total population suffers from obstructive CRDs. Globally, the prevalence of CRDs is increasing. This increase is caused by the aging population and augmenting prevalence of risk factors, such as air pollution. The management of obstructive CRDs focuses on controlling the symptoms and improving the quality of life, as these conditions are incurable. Accordingly, the management of these conditions require a multidisciplinary approach. In Belgium, the management of obstructive CRDs account for 10% of the annual care expenses. The effect of osteopathic manual treatment, OMT, and pulmonary function has been frequently studied in obstructive chronic respiratory diseases, CRDs. These studies derived in search of cost-effective, non-invasive forms of treatment. Most of these previous studies had inconclusive results. The effect of OMT on posture and the influence on posture requires further research, as the literature on this topic is scarce. The standardized OMT protocol for this study was devised to improve the overall thoracic mobility via mobilizations of the upper thoracic vertebrae and adjacent ribs, and stretching of the intrathoracic fascia. OMT aims to increase the function of these structures by improving their mobility. The mechanical, neurological, and vascular functions of the upper thoracic vertebrae and ribs will be discussed later in this presentation. Fascia have only been studied recently. The thoracolumbar fascia does influence posture and pulmonary functions by means of the abdominal wall muscles and its connection to the diaphragm. The function of the intrathoracic fascia in respiration and posture is less distinguished. However, the general morphology and functions of fascia imply a mechanical function in posture by means of its connection to the thoracic wall muscles and its ability to convey mechanical forces throughout the body. The fascia are made out of fibroblasts, which also have a proprioceptive function. This function implies the neurological component of fascia and posture. Objective. The primary objective of this study is assessing the effect of standardized OMT of the upper thoracic region and intrathoracic fascia on respiration and posture in order to determine the role of OMT as a complementary form of rehabilitation in chronic respiratory diseases. Secondly, the study will research the effect of standardized OMT of the upper thoracic region and intrathoracic fascia on respiration and posture in healthy subjects. Hypothesis. HO. Symptomatic subjects with obstructive CRDs who receive standardized OMT of the upper thoracic region, including the intrathoracic fascia, exhibit improved pulmonary function and posture compared to the symptomatic control group. H1. Asymptomatic subjects who receive standardized OMT of the upper thoracic region, including the intrathoracic fascia, exhibit improved pulmonary function and posture compared to the asymptomatic control group. Study design. A single-blinded, randomized controlled trial was conducted at the Skills Lab of the International Academy of Osteopathy, Klein Dokkai 3-5, 9000 Gent, Belgium. 43 subjects were recruited between the age of 18 and 60 years old. The mean age was about 34 years. The subjects subdivided into 4 groups. The randomization was limited to a 3:1 ratio. Group 1 included asymptomatic subjects who received OMT. Group 2 included asymptomatic subjects who received sham therapy. Group 3 included symptomatic subjects who received OMT. Group 4 included symptomatic subjects who received sham therapy. Subjects were allocated in the symptomatic control and trial group according to the European Respiration Guidelines on the interpretation of spirometry measurements. The researchers were 2 female and 1 male final year student of the International Academy of Osteopathy in Ghent. Researcher 1 made sure the subjects read and signed the informed consent. Researcher 2 measured the subject's weight, height, pulmonary function and posture. Researcher 3 performed the 2 interventions. The measurements were taken before, in between and after both interventions. Safety. The informed consent assessed the presence of the following exclusion criteria for this study. In that manner, the safety of all subjects was reassured. To measure pulmonary function, the SpiroBank 2 smart spirometer was used and a forced vital capacity maneuver was performed. This maneuver captured the main spirometric parameters listed below. To measure posture, a Deers Phometric 4D scanner was used. This appliance evaluates posture in a non-invasive way, by means of the curvature of the projected lines on the subject's back. The curves in which the lines were projected on the subject's back were converted by calculations to form a 3D image on the computer. The outcome measures only included variables which evaluate the thoracic kyphosis, as a hyperkyphosis can be observed in asthmatic subjects, and as it is a common postural dysfunction. The intervention protocol of the active treatment groups consisted of mobilizations of the upper thoracic vertebrae and adjacent ribs and stretching of the intrathoracic fascia. The first intervention targeted the upper 5 vertebrae and upper ribs and consisted of 10 techniques. The second intervention targeted the intrathoracic fascia and consisted of 5 techniques. Both interventions were standardized in duration and execution. Intervention 1 consisted of following techniques. Intervention 2 consisted of following techniques. The sham therapy consisted of a light touch protocol. The thoracic vertebrae T1 till T5, as well as the sternum, upper ribs, dorsal and ventral, on the left and right side, were sequentially contacted by the researcher. This contact did not induce any mechanical changes. This intervention protocol was also standardized in duration and execution. Statistics. The collected data were analyzed by the MedCalc program. This program was developed and distributed by MedCalc software. First, each parameter was compared before and after both interventions within each group. A paired sample t-test or Wilcoxon test was used to calculate the p-value. These results are summarized in Table 2 and Table 5. Secondly, the pre-intervention and post-intervention data were compared between Group 1 and 2 and between Group 3 and 4 by using a student t-test or a Mann-Whitney U-test. The results are summarized in Table 3, 4, 6 and 7. The value for statistical significance was placed at 0.05. If the value is less or equal to 0.05, there is a statistical significant correlation. For none of the parameters, a p-value of 0.05 or less was found, except for 3 out of 4 Deers variables within Group 2. This unlikely occurrence remains unexplained. So finally, Each parameter was evaluated to verify if there was a positive or negative tendency. This qualitative study is summarized in Table 8. Results. In comparison with sham, both symptomatic and asymptomatic subjects who received active treatment showed no significant improvement in posture and pulmonary function. The general characteristics of the total population are summarized in Table 1. The following slides represent the results of our research. Discussion. None of the results had statistical significance and thus do not support the hypothesis of a positive effect of OMT of the upper thoracic region, including the intrathoracic fascia, on posture and pulmonary function. However, 3 out of 4 DIRS parameters within the asymptomatic control group were statistically significant. No valid causes were found for these unlikely results. As none of the other p-values were equal to or less than 0.05, a qualitative interpretation of the pre- and post-intervention data was conducted. This interpretation showed an overall positive tendency in both asymptomatic and symptomatic groups who received OMT. The strength of this study are the use of multiple spirometric and DIRS parameters and a single-blinded research protocol. The randomization was also limited to a 3:1 ratio due to safety and organizational measures. The overall negative results can be explained by the several limitations of this study concerning the measurements and the intervention protocol. The spirometry proved to complicate this research. Most subjects were unfamiliar with the spirometry process and it was conducted by students. The general structure of the intervention protocol could have had adverse effects on the hypothesized outcome. The intervention consisted of a sequence of techniques which were non-individualized. Furthermore, it is unlikely that a single intervention could be sufficient for a posture correction. Previous studies consisting of rehabilitation exercises over longer periods of time proved to be effective. Previous studies concerning OMT and pulmonary function focused on the treatment of different anatomical regions than our research. These previous studies concerning OMT and pulmonary function focused on the upper cervical vertebrae, thoracic inlet, the diaphragm, and techniques to improve lymphatic drainage. Apparently, the thoracolumbar junction had a greater influence on respiration than the thoracic spine as it forms the insertion of the diaphragm via the crurae. Neurologically, the upper thoracic segments form the sympathetic innervation of the vasculature of the airways. OMT of these segments aim to lower the sympathetic output to the effectors, which is supported by previous studies. Spinal manipulation of the upper thoracic vertebrae showed no significant changes in sympathetic output. If the aim is to neurologically improve pulmonary function by OMT of the sympathetic segments T1 till T5, the effect is questionable. The asthmatic pathology involves a parasympathetic dysfunction. Also, the sympathetic nerve supply to the lung is scarce. Little is known about the role of intrathoracic fascia on pulmonary function and posture. Further research is needed. This study had a small sample size of 44 subjects with a mean age of 34 years. We found 2 age clusters, one with older symptomatic subjects and one with younger asymptomatic subjects. Another lack in this study was that the tested population was predominantly female and completely of Caucasian origin. Therefore, the results of this study cannot be generalized to the Belgian population. Conclusion. The study does not support OMT of the upper thoracic region, including the intrathoracic fascia, to be useful as a complementary form of rehabilitation in obstructive chronic respiratory diseases, nor does it support to influence posture. Considering the several limitations of the study, more research is needed.